So I'd like to welcome you all to the pre-conference workshop organised by the Paediatric Special Interest Group, and in particular Jordan Wood, Rebecca Finnegan and Karen Plummer, who were responsible for organising the program for today. We've got a sponsor who we would like to acknowledge and thank, and that's Move Victoria, and they've got a stand outside. They've got some very useful information, including a publication around pain, which is suitable for children to read, and which they're giving away free copies. So I'd all encourage you to go and visit their stand. The other thing we'd like to encourage you to do is to, if you're not already members of the Paediatric Special Interest Group, to join, because it's a growing, dynamic, young, not so young bunch of people. And I think it's important that we all work together to keep on advocating for children in pain in Australia and Victoria and all the other states, of course. So it's a very important thing. It's only, I think, another $20 to your membership, and that's important because that's how the Special Interest Group is funded, and we've got a bunch of costs that we need to cover. The other thing I'd like you to do is just switch off your mobile phones if you've got them with you. I think most of you do, so if you don't mind switching them off. And for those of you who are coming to the dinner tonight, I think that's going to be quite good. I'm not sure if there are any spots left if anybody hasn't registered for it and wants to come, but you can go and ask at the reception desk downstairs. Now, I'm just going to delay things a little bit because our first speaker is running a little bit late. He's here and he's loading up his talk. But I will introduce him whilst I'm waiting. His name's Mark Alcock, and he's the head of the chronic pain service at Lady Cilento in Brisbane in Queensland. And it's a relatively new service that's been set up, and he's been there now for probably since June last year and has been involved in the establishment of the service, which had already had a rudimentary service prior to that, which was staffed in a multidisciplinary way, but he's had a few challenges along the way and some changes, and he's going to talk about his experiences. And his talk will be entitled From the Ground Up, Constructing a New Children's Complex Pain Service. And whilst we're waiting, the other thing I'd suggest is that we'll keep all the questions to the end. So each group of speakers have got 20 minutes to talk, and then we'll invite all the speakers up to the table and take questions. And when we do take questions, I'd like you to step up to the microphone and just introduce yourself so we can all get to meet each other and know who's talking. Now, I'm not quite sure where Mark is, but his talk is there, so he must be only seconds away. He'll probably be a little bit flustered when he gets here. And if you'd all like to stand up and welcome Dr. Mark Alcock. I've done his intro.
Thanks, George. Sorry I'm a bit late, but my name is Mark Alcock and I'm a pain specialist and the clinical lead of the persistent pain service at Children's Health Queensland. And today I'm going to talk about the development of our service over the last couple of years since we secured funding. So I'll provide a background on how the service ran prior to funding, outline the development of our service delivery model in the first 12 months, and then again over the last 9 months since I started as the clinical lead. And also talk about our governance structure and processes and our vision for the future. Prior to funding being secured, the paediatric persistent pain services at Children's Health Queensland were dependent on the goodwill of staff from the anaesthetic department, the Division of Medicine and the Division of Clinical Support. Services were provided on an ad hoc basis and often in a crisis response mode. Many years were spent lobbying the state government to fund a paediatric persistent pain service. And unfortunately, in the 2010-11 financial year, when the Newman government committed nearly $40 million to persistent pain services in Queensland, paediatric pain missed out. It was another 5 years before the Alecia government made a commitment to fund paediatric pain. They've allocated 4 years of block funding, increasing from $500,000 per annum up to $1.7 million per annum over 3 years, and with a plan to move to activity-based funding for the 2019-20 financial year. Whilst planning our service development, to provide a starting point, I asked myself why it's important to have a paediatric persistent pain service. The two reasons that I could come up with were, firstly, paediatric persistent pain is common, with wide-ranging impacts on patients, families, communities and the healthcare system. And secondly, paediatric persistent pain is a complex and heterogeneous problem that requires expertise to assess and manage appropriately. I regularly remind myself of the first reason because it gives me the big picture perspective on what I'm tasked with as the lead of the service. It's very easy to become consumed with individual challenging patients as a clinician to the detriment of the patients themselves, of their families and of clinicians, other patients and the healthcare system. Appreciating the wider impacts of paediatric persistent pain is vital in developing a sustainable service delivery model, as well as developing the interface of the pain service with its stakeholders. The second reason has driven the how and what we do on a day-to-day basis. The evidence base for paediatric persistent pain management is still young, and whilst at a macroscopic level there are things that we know that are good and bad to do, there is little to no evidence to guide us on the details of how a service should be structured or how the literature that is available should be applied to our local practice. The limitations of our evidence base are reflected in the variance of paediatric persistent pain service structures around the country and internationally. Our services structure has my own stamp on it, which reflects my experiences and beliefs about paediatric persistent pain management. I joined the service as a clinical lead in June 2016, 12 months into the block funding. In April last year, we had 3 planning days that enabled us to meet as a group for the first time and discuss our service delivery model. We have followed this up with 2 service review days since my arrival, with a plan to run more as our service continues to evolve. These days have been valuable, dedicated time to review our progress and direction. The development of our service delivery model is a journey that has already seen significant restructuring. Speaking to the people who were on the ground at the time, the funding came as a bit of a surprise, and with a sense of urgency to recruit staff and get things moving. With Dr. Kathleen Cook stepping back and going on sabbatical, 2 paediatricians ran persistent pain clinics. In the early months of 2016, allied health staff were recruited. Referrals to individual practitioners were made from the pain clinics, and when needed, multidisciplinary assessments were conducted by admitting a patient to the medical day ward to enable the allied health team to see them. Therapy was centred around goal-directed 1 to 2 week blocks of inpatient therapy, supplemented by outpatient appointments for local patients. In addition to this, there was an increasing demand on the allied health team to provide an informal consultation liaison service for new inpatients with persistent pain, with the allied health practitioners being contacted directly by inpatient services. The structure changed with my arrival in June 2016, preempted by the planning days we'd held in April. At this point, an interdisciplinary assessment clinic was established to complement the medical clinics. This encompasses a biopsychosocial assessment, formulation and patient and family feedback all on the one day. We are lucky enough to have a psychiatry 0.2 FTE appointments with our service. As our psychiatrist described it, the mental health scene in the paediatric pain clinic is definitely not mental health light, and psychiatry input into assessment is invaluable. Following the interdisciplinary assessment, on assessment day we have a 1-hour patient review meeting where we discuss patients who are engaged in therapy with our service. Following this, we have a service meeting that rotates on a 4-week roster between a business meeting, a journal club, an education session, and a research/quality assurance/conference meeting. Our therapy delivery model has moved away from inpatient rehab admissions to outpatient appointments. We have admitted 2 patients to the mental health ward as part of their pain management, both patients who were not making progress with the outpatient approach, and we are looking to foster the relationship between our service and the mental health services. All referrals to persistent pain must now be medical to medical, and as the clinical lead, I've stopped our allied health team from providing a consultation liaison service for new inpatients with persistent pain. Referrals from acute inpatient services are now redirected to the outpatient clinics wherever possible. Whilst we don't have a formal persistent pain consultation liaison service, informally, I am contactable by phone, and if on the occasion it is required to see an inpatient, one of the medical staff or our nurse practitioner can usually do this within 2 to 3 days. We've communicated these changes to our service delivery model in a number of ways, including a grand round presentation, meetings with the directors of other services, talking at departmental business meetings, developing a referral template, and putting information about our service on the hospital's webpage. Whilst changes to how our service is accessed by referrers has been met with some resistance, I feel these changes have been important in creating sustainability in our service delivery model, and I'm comfortable justifying these changes. I think the purpose of an acute inpatient admission for a persistent pain patient is to facilitate the completion of investigations. Admission to the mental health ward is indicated if immediate risk of deliberate self-harm or suicide is considered significant. Under some circumstances, providing temporary respite for the patient and or the family may be reasonable, but generally I don't think high levels of pain intensity, distress or functional disability are reasons to admit persistent pain patients. Trying to conduct a persistent pain assessment or initiate management in the inpatient setting is not very effective in my opinion, and doesn't appreciate that these patients are presented to an acute care environment, not with an acute medical problem, but with a chronic biopsychosocial problem that has reached the crisis threshold. Redirecting to the outpatient setting may be therapeutic by discouraging the sick role, promoting an internal locus of control, and reinforcing the timeline on which a subacute to chronic problem is managed. Asking our allied health team to see new inpatients acutely pulls them away from outpatient clinics and often places them in a difficult situation that is emotionally charged with unrealistic expectations from referrers, patients and their families. Our allied health team has been restructured since my arrival. Initially, the team was made up of 5 allied health disciplines: psychology, physiotherapy, occupational therapy, music therapy and social work. Having 5 disciplines created challenges coordinating interdisciplinary assessments and therapy, and clashes in therapeutic agendas. These challenges were exacerbated by employing staff on temporary contracts, a step that was necessary for seeing the inevitable restructuring that occurs when a new service evolves. Since June last year, we've trialled 3 models in our interdisciplinary assessment clinic, transitioned social work out of the team, focused on growing the psychology, physiotherapy and occupational therapy positions in our upcoming recruitment campaign, and moved to utilise music therapy selectively with internal referrals. The result has been the development of a sustainable and comprehensive service delivery model necessary for the most complex patients. The process to get here has been unsettling as conflicting views and questions of self-validation, roles and responsibilities are inevitable. Looking at our governance structure and processes, our service sits within the Department of Anaesthesia, which is part of the Division of Critical Care. Many persistent pain services sit within anaesthesia departments, a coupling of 2 very different specialties, and a structure that results in a pain specialist clinical lead reporting to a non-pain specialist director. We have been lucky to have strong support and transparency from our governance, from the Director of Anaesthesia all the way through to the Chief Executive Officer. This support and transparency is dependent on the personnel in those positions, and in our case, they valued and advocated for a persistent pain service. It could become fragile when personnel change. One way to make this structure more resilient would be to change the clinical lead of the pain service to a director who would sit alongside the Director of Anaesthesia. However, this structure may be difficult to implement in a small and new service, particularly if the clinical lead is new to leadership roles such as myself. Our service has its own budget and cost centre, separate to the Department of Anaesthesia. As the clinical lead, I meet regularly with the Division of Critical Care's operations manager and accountant to discuss and track the allocation of this money. A lot of tasks such as finding clinic space, establishing booking processes, developing service priorities and maximising revenue from outpatient activity, which is vital for transitioning to activity-based funding, are not intuitive to me with a background in anaesthesia, or our administrative support and governance, who are an acute care division. Fostering relationships with established outpatient and multidisciplinary services and their departments and divisions is helpful. Administrative systems in place are not always easily adaptable to our service delivery model. For example, we run our interdisciplinary assessment clinic in an allied health clinic which does not have the capacity to perform medical billing, and our billing systems do not allow us to capture both medical and allied health activity when we perform an interdisciplinary assessment. We work closely with the Division of Clinical Support, and we have a memorandum of understanding to formalise our relationship with them. This document was formulated jointly and is to be reviewed annually. And it outlines duties including reporting lines, operational and professional responsibilities, leave cover, and service delivery and on-call commitments to both our service as well as the allied health departments. Prior to my arrival, the proposed vision that came with the funding was to develop a hub-and-spoke statewide paediatric pain service, with the hub being the service at Children's Health Queensland and spokes being services throughout regional Queensland. This is a long-term plan that requires further funding, recruitment and training of staff, and local supports to build resilience in the spoke centres. We do accept referrals from all over Queensland, as well as northern New South Wales, and nearly 50% of our referrals come from outside of the Brisbane metro area. Managing persistent pain over distance is challenging. Currently, for patients that would need to drive many hours or fly to come and see us, our first step is to conduct a telehealth appointment. The purpose of this is not to do an assessment, but is to establish whether the investigative process for their pain has been appropriately completed, and also to manage the expectations of the patient, family and referrers, and define the purpose of travelling to Brisbane for an interdisciplinary assessment if that is done. It also helps to identify local resources that can be utilised in a patient's pain management. Training and education. We have had a paediatric palliative care fellow work with us on assessment day for the second half of last year, and this year we've established a 0.5 FTE pain fellow position. This has been filled by a paediatric palliative care specialist who is wanting more experience in persistent pain. We would like to increase the FTE of this position to 1 and encompass more acute pain and palliative care exposure into the job, with a view to becoming an accredited training service with the Faculty of Pain Medicine. We realise and welcome our responsibility as a tertiary centre to train paediatric pain specialists and increase opportunity for general pain specialists and paediatricians who work throughout Queensland to gain experience in persistent pain and paediatrics. Similarly, we want to increase the paediatric pain management exposure to allied health staff throughout our hospital and throughout the state. At a hospital level, opportunities may arise through leave cover and elective rotations and secondments from the allied health departments, although this is dependent on staffing of those departments, which is not reliable. We have had allied health practitioners from external services and students come and observe our clinics, and we encourage this. We fully acknowledge that we are a young service led by myself, a junior pain specialist who has taken on a leadership role for the first time. We, and myself in particular, have made mistakes and we will make more mistakes. Whilst we are treading our own path, networking with the pain community and seeking feedback on our service as we develop is highly valued. We've recently conducted a strategic service delivery consultation, a day where we invited 4 consultants from varying backgrounds within the persistent pain community to come and meet with members and stakeholders of our service. The outcome of this consultation will be written reports addressing questions that we are asking ourselves as we develop. From the 1st of January this year, we've formally started participating in EPOC. This important activity will enable us to benchmark with other services and provide opportunities for research and collaboration. We are grateful to be given opportunity to present in forums such as today, to showcase what we are doing and hope it encourages constructive feedback and discussion. As we look to the future, we are about to embark on a recruitment campaign that will see the appointment of an allied health team leader and additional allied health practitioners with the aim of increasing the capacity and resilience of the heart of our service, the allied health team. We will continue to innovate our service delivery model. Some examples of innovations we've achieved so far include our structured education session that can be individualised to patients and families, which is based on an education session developed by the Pain Service at Royal Children's Hospital in Melbourne. Our physiotherapist has also started a group therapy program this year, where selected patients can come for an hour once a week during the school term to work on skills and exercises that they've learnt in individual sessions. The question of whether we should develop a more formal group program has come up a few times from different sources and is worth consideration. Most important is considering what the goals are of a group pain management program and how it fits into our overall service delivery model. An advantage is the ability to provide therapy to multiple patients at once and the potential to attract increased activity-based funding. A packaged group program may also be more accessible for patients who live remote to us. However, I don't think it should replace an individual approach as the main therapy modality, as I'm not convinced of the capacity to provide an in-depth assessment and management of patients in a group setting. For example, perhaps our number one key performance indicator is getting children back to school, and with an individualised approach, I think we are good at achieving this. Exploring and addressing possible reasons for poor school attendance beyond the symptom of pain, such as social anxiety, learning difficulties, secondary and tertiary gain, may be difficult in a group environment, as may be exploring family dynamics. Supporting patients and families through transitions such as return to school, entering high school, doing examinations, and individuating as patients go through adolescence may also be more difficult. So in conclusion, the last 2 years has seen our service grow from an unfunded, ad hoc and often crisis response service into a young, coordinated, interdisciplinary outpatient service. The relationship between our pain service and our hospital has changed, and the hospital is slowly adjusting to this. Restructuring of our service delivery model has occurred as we learn from our experiences. This has been challenging but necessary and helped us create a model capable of assessing and managing the most complex persistent pain patients. We are keeping pace with our referral demand. The unmet need for paediatric persistent pain services throughout Queensland is, however, unknown. Our governance structure is working because key personnel are supportive and transparent. Creating links with other outpatient and multidisciplinary services to help advance our own service processes is invaluable. There is a vision for developing a statewide paediatric persistent pain service, which requires funding, recruitment and training of qualified staff. As we tread our own path, we welcome opportunities to engage with the paediatric pain community and encourage constructive feedback and discussion. Thank you.
Where's Jordan? Actually, I'll be fine. You got over? Okay, our next presentation is going to involve 2 speakers, and to in order to sort of continue for continuity, we've got two speakers from Lady Cilento, where Mark is now based. And one's Rebecca Fechner, who's a physiotherapist, and the other is Zoe Jones, who's an occupational therapist. And they'll be talking on graded motor imagery for children and young people with persistent pain. So I'd like to welcome you up to the stage.
Good morning, everyone. So I'm Zoe and this is Beck. And as you know, we're going to talk about GMI for children and young people with pain. And I guess Beck and I are interested in this topic because we've used it in our clinical practice and we're really keen to kind of demonstrate how it can be used on a day-to-day basis. So what we're going to do is talk about what GMI is. We're going to look at GMI and body perception disturbance. What is the evidence for GMI in children and young people? How GMI can be used in an interdisciplinary or multidisciplinary team, and we'll use a case study to demonstrate this. And could the concepts of GMI be used for other childhood conditions?
So what is GMI? So GMI stands for Graded Motor Imagery, and it's a brain-based treatment that targets the activation of different brain regions in a graded manner. It's developed by the Noy Group and is based on three health paradigms. First of which is the biopsychosocial approach, which incorporates the biomedical drivers for pain, as well as the impact of psychological and social factors on pain. In other words, it incorporates how the problem is lived. The neuromatrix paradigm, which allows for access to the representation of our bodies and our lives in our brain. And the pain mechanisms paradigm, which incorporates recent knowledge about the speciality of pain, including our understanding of brain pathways, brain plasticity, how brain and stress are made in the brain, mirror neurons, and the knowledge about graded exposure to activity and frameworks for assessment. So GMI is based on 3 stages, the first of which is left-right recognition or discrimination. The second is imagined movements or explicit motor imagery. And the third is mirror therapy, with the ultimate goal of functional integration. So left-right recognition. So this is our ability to judge our left and right sides of the body and its parts. In other words, it helps to promote precise neurotags in the brain. With persistent pain, the sensory homunculus becomes smudged. That is, body parts become smudged on the sensory cortex in the brain. In this case, body-related neurotags lose their normal inhibition. Disinhibition results in a disruption to the perception of the body part, its sensory function and movement commands. So smudging on the sensory cortex is thought to be related to body perception disturbance. Hence, it is important to consider this as impacting the pain state and barriers to treatment.
So what is body perception disturbance and how is it relevant for pain and using GMI? So to maintain a sense of body ownership, there must be congruence between vision, proprioception and tactile sensation. To perform a functional activity, proprioceptive, vestibular, somatosensory and visual inputs from the periphery interrelate with our motor system to produce a coordinated activity. So body perception disturbance can be defined as an individual's perceived alteration of their affected body part while regarding the remainder of their body as normal. So this could be distortions in shape, size, weight, pressure or temperature that is different to the objective assessment. They could have loss of specific anatomical parts during mental visualisation, hostile feelings towards that limb or a sense of disowning the body part, impaired limb position sense, and in extreme case a desire to amputate that part of the body. So recent evidence suggests that body perception disturbance is becoming an increasingly recognised feature of CRPS, with a reported prevalence ranging from 54 to 84%. We've just listed a definition of CRPS if you haven't heard of it before. So in CRPS, altered body perception and proprioception may also be present, reflected in reduced limb accuracy, delays in recognising the limb left-right judgments, like Beck has spoken about, abnormal referred sensations and tactile perceptions, and altered subjective mental representations of the limb after similar tissue trauma.
So back to the stages of GMI, the second stage is explicit motor imagery or imagined movements. So imagining yourself moving a body part, which is the result of conscious access to the neurotags representing intention, preparation, carrying out and evaluation of a movement. This can often elicit pain and often needs graded exposure and pacing of these imagined movements. And the third stage is mirror therapy. So mirror therapy can be described as a form of brain trickery in which the mirror provides visual feedback of the healthy limb that looks well and is fully endorsed by the brain. Mirror therapy provides a smaller jump in terms of the threatening load from explicit motor imagery into functional exposure. The evidence shows that patients report they are more willing to look at a limb as a consequence of mirror visual feedback. They have greater ownership and improved emotional attachment to the limb, hence improving body perception.
So what does the evidence say for the use of GMI in children and young people? So as you can probably imagine, there's not a lot of studies that use GMI for children and young people, but there's lots of opinions about it. So this could be due to lack of research completed in this area. It could be difficult doing research as GMI is used differently and it's often not a linear approach or process. And perhaps it's hard to follow up or control how children and young people do this in the home environment and follow up how it's performed. So some articles talk about the use of GMI on controlling the pain associated with other chronic childhood diseases that are listed on the slide. GMI is also thought to improve mobility and reduce the level of inactivity, so a state of fitness is achieved, which could improve the prognosis of the disease itself. There are some articles that say that there may be some need for specific protocols to use with kids if you're doing GMI. But even though there is some lack of really specific evidence, we believe that we can still draw some conclusions and see how it works in our clinical practice.
So as Zoe mentioned, it's important to note that GMI is not a completely linear process. And if we have a look at the slide, you can see the Noi group have illustrated it by a stepped approach. So we have an understanding that there's a continuum of therapy that runs from recognition and watching to visualisation and eventually to progressing into motor tasks. As barriers come up in a patient's treatment, it may be that we have missed a step or need to concentrate on one particular step a bit more in order to address the particular barrier to treatment. We use the Noi groups, DIMS and SIMS, to assist in problem-solving barriers and apply them along the continuum of the GMI framework. When we feel pain, our brains perceive a credible evidence of danger. Dangers, or DIMS, as the Noi group describe them, such as dangers in me, can be past experiences, memories, thoughts, beliefs, people who may influence the pain, environments that may make the pain worse. In order to change the pain experience, we need to identify SIMS, which we call safety in me. And these are things that are often positive or tip the scale toward a lower pain experience. The team can work on SIMS to encourage a barrier to treatment or even use DIMS, or dangers, to change the context of treatment and progress patients. Examples will be shown later in the presentation.
So we thought we'd use one of the case studies from our hospital. So this is the fake name Leah, and she is a 15-year-old girl, and you can see by reading the slide the different things involved in her life and why it's important to have an interdisciplinary or multidisciplinary approach. So just to point out, Leah has CRPS. She's got some body perception disturbance, so she's not recognising her foot. She's got this dislike of the foot with CRPS, and she's got some sensitivities to wearing shoes, for example. So before beginning to treat Leah, it's really important to consider a number of things. So treatment for CRPS involves the use of GMI. It's important to address Leah's body perception disturbance issues that she's noted about her lower limb. So she's got a smaller or skinnier leg because of her CRPS, and she's got this disownership of her limb. So when she looks in the mirror, she says she doesn't like the way that it looks. She doesn't want to touch it, and she doesn't want this to be part of her body anymore. So the evidence says to address body perception disturbance, it's important to provide corrective input to normalise attitudes, perceptions and emotions about the affected limb, to look at and to touch the affected area where tolerated, and provide corrective sensory inputs to accurately update the body schema. Think about the limb in a more positive way. And as I've said, it's important to ensure that the whole team that you're working with is trying to address body perception disturbance and knows how to treat it. So although we didn't use it in this case, you could use the Bath CRPS Body Perception Disturbance Scale, and this scale specifically asks questions about body perception disturbance. It asks about their thoughts and feelings about the limb, and it can be useful during the assessment phase of CRPS. So Leah has demonstrated body perception disturbance in her case, and the need for the entire team to get involved with understanding it and using GMI to address her number of issues that were listed before.
So the NOI group have developed the Recognise app to address left-right discrimination. So we'll talk about using this left-right discrimination with Leah. So the app is a collection of images that pop up on the screen in differing contexts and positions, as you can see in the picture up there of the foot. It's aimed at improving the left-right recognition. That is, it is thought to reduce the smudging in the brain by improving the precision of the neurotags. In our experience, left-right recognition doesn't just have to be about the Recognise app. Clinical judgment and experience obviously guides treatment. However, an awareness of the left-right discrimination or recognition, body perception disturbance, and its importance on the rehab of the patient helps to guide treatment and address barriers. With Leah, we use pain education to normalise her perceptions around pain and hypermobility. We use neurophysiology education to assist in ownership and acceptance of her limb as her own, to help her understand the messages being sent to her brain and also how to change the pain experience for her. Reinforcing the ownership of her limb and normalising the limb by comparing it to the other side was also important in this stage. For example, with Leah, it was wearing the same shoes on both feet. For younger children, left-right discrimination or implicit motor imagery could be addressed and treated slightly differently. For example, if you had a 7-year-old that couldn't tell the difference between left and right, but perceived their right foot as bigger than their left or perceived it as swollen and damaged, the treatments could include psychological interventions tailored towards thoughts on that body part compared to the other, pain education tailored towards the developmental age with drawings about the nervous system and how it works, games like Twister to help build awareness of the body part, songs that include both parts of the body, and magazines looking at feet or the limb in all different contexts and positions.
So for Imagine movements, when looking at Leah's case, like any patient, it's important to remain goal-directed. So Leah identified her main goal to be able to wear thongs so that she could go to the beach and, wear easy shoes to put on. So we can break down this task using GMI. So we got her to imagine wearing thongs, but she tried practicing this and she was fearful because she was fearful of when she walked in thongs that they would slap the bottom of her foot and it would hurt. So we had to break down the task further using the DIMS and SIMS that Beck spoke about earlier. So SIMS for wearing thongs would be that they're not as hot, they're convenient to put on, you can do more family activities like, going to the beach and going and helping out in the garden if you need to. And so we tried some graded exposure with first imagining her wearing the thongs to progressing to slipping them on when sitting, to imagine wearing them in her bedroom or in a safe environment where she felt comfortable, to wearing them outdoors and actually walking in them. So other examples could be that it's really important to note that when children have a very vivid imagination, or they can have, so it's really important to set the scene and understand how they perceive the movement. So encouraging it to start in a safe environment where they feel comfortable. So sometimes it could be their bedroom. If that's where they consider safe, it could be with people that they trust and where they feel really comfortable. So with younger children, you might need to ensure that you're actually getting the feedback as to whether they're actually doing the imagination. So you could try, really tapping into their imagination further by asking them things like, pretending that you're walking on a soft, fluffy cloud, eating fairy floss, and get them to give you some feedback. So what does that look like? What does it feel like? What is it that's around you? So using mirror therapy for Leah, it's important for her to perceive her limb in a normal way and address this body perception disturbance further. So the evidence says that patients can use mirror therapy to have a greater ownership and improved emotional attachment to their limb. So we used mirror visual feedback as a way of looking at proprioception and balance with Leah, by helping her to send messages from her brain to her limb around the ownership. So getting her to actually use phrases like, this leg is designed to hold me up and I can trust my leg again. Getting her to understand how much weight to put through the limb for functional tasks and to promote that cortical reorganisation. We also use desensitisation with Leah through the GMI process to normalise touch and to use the mirror to accept her limb and further reduce body perception disturbance. It's important not just to use desensitisation as a way of sensory exposure, but to talk about the context, address her beliefs, and use different textures and apply it to real life examples. So if you were using a cotton wool ball, for example, to start the desensitisation process, you would talk about the beliefs around it as well, you know, that this kind of item can't cause harm, but what else does it remind you of? So it might be soft like your towel at home. So therefore we could start trying to do things like being able to dry your foot at home. And Leah was able to do this and apply it to real life context to progress further functionally. So we could use mirror therapy to really help Leah feel safe and comfortable to progress to wearing her thongs again.
So from mirror therapy and mirror feedback, we then begin the transition to functional integration, which most of us identify as the physical rehab stage. So for example, with Leah, if we think of her goal of progressing to walking with thongs, we're able to progress her balance, strength, proprioceptive exercises, and eventually walking on sand with thongs. We were able to use a lot of the strategies learnt through the GMI process and apply them to exercises as barriers came up. It's important to note that Leah had tried all of these exercises prior to attending the pain service with not much success. With the use of GMI and strategies that she learnt along the continuum, she was able to problem solve those barriers as they came up. We also use music to assist with the visualizations. So for example, with Leah, she had specific relaxation music that she used for visualizing herself in thongs on the beach. She used this prior to her first beach trip. Our psychologists use psychological strategies like deep breathing and intervention to address her thoughts along the continuum. Continued pain education to address understanding of her body and to allow for better pacing, and pacing tools to assist with making decisions about her body in the present moment and having control over these decisions, hence allowing for eventual self-management. With Leah, as we work towards different goals, some of the barriers that came up for her were her body schema. She had waves of disliking her limb, which meant that we had to readdress implicit motor imagery or recognition tasks and limb acceptance with the whole team, including a lot of psychological interventions. Another barrier that came up often with Leah was anticipatory anxiety, and one of the examples was when she was going onto point shoes during her dance class. Continued recognition tasks like looking at the feet in point shoes, imagined movements emphasising her sims, mirror therapy with point shoes, and emphasising pain management strategies throughout all these stages helped her to achieve her goals. Leah was also involved in group therapy, which involved exercise and activities with other girls with similar pain conditions. This was a good way to reinforce all the pain management strategies she had learnt along the GMI continuum and helped Leah to problem-solve barriers herself. This continued practice of self-management strategies has allowed Leah to re-engage at school, wear thongs again, and get back to her love of dancing.
So we hope you've gained a bit of insight into working with children and young people and how GMI might be able to be used in clinical practice. We just want to finish with some food for thought. So we've talked about GMI and body perception disturbance, and in our clinical practice we've noticed a lot of children with poor body awareness in general, and that perhaps there's a link between body perception disturbance and the development of pain conditions. So there's an article that suggests that disturbance of body awareness may precede the development of CRPS. There's also a systematic review that looks at children with developmental coordination disorder, or DCD, which includes deficits in motor skills and coordination and reduced participation in leisure activities. And this is said to be prevalent in 5 to 6% of children. So treatments for DCD seem similar to that of GMI. So they look at neuromotor task training, motor imagery, combined with practice of motor tasks. So what if we're seeing these children with poor motor skills who withdraw from sport and leisure and are not getting to experience those normal body movements and therefore not developing a normal body perception as they develop? Do these kids end up in our pain clinics? So we don't have any answers to this, but are there links between body perception disturbance, children with DCD already, and therefore the development of pain conditions? And can GMI be useful for child development interventions? This is just a bit of food for thought.
So in conclusion, just a summary, GMI is a therapy for adults as well as children and young people. GMI is useful for several childhood conditions. Body perception disturbance can be under-recognised and a barrier for progression in therapy. GMI can be used by the entire MDT or IDT. GMI in children and young people has been demonstrated clinically today, and there may be children and young people more susceptible to persistent pain, and early GMI may be useful. Further research needs to be completed. So we've also have a list of references for some of the evidence we've spoken about today. Thank you very much.
Well, thank you, Beck and Zoe. That was a real team approach. So our next speaker is going to be talking on multidisciplinary telehealth and paediatric pain medicine, and it's Hema Rajappa. I'd like you to come to the stage, Hema, and look forward to hearing your talk.
Thank you all for being here today on a Saturday morning. We'll get started straight away. So a bit of background about myself. Not work, sorry. Can I have a little bit of help, please? Just try.
Should be that.
Yeah, it doesn't want to do it.
Why don't you just use that?
Try that as well. And try that as well. Yep.
We haven't got any.
I've got a stick as well on me.
That should be working.
Oh.
Okay.
They're just stuck. Maybe.
Just have to press it forcefully.
Okay. Thanks for that. So I'm a general pediatrician by background, and I'm a specialist pain medicine physician. I work with children, adolescents, and young adults with pain. I work for 3 pain services in our local area health district, that is Hunter, New England. And that little map, which is not very clear, I'm sorry. The yellow region is our district, and the 3 services are marked there: the Tamworth Integrated Pain Service in regional New South Wales, and the Hunter Integrated Pain Service, which is an adult service, and the Children's Complex Pain Service, which is the pediatric pain service based at John Hunter Children's Hospital, Newcastle. So this is a fairly biggish area health district, as you can see, more than 100,000 square kilometers, and nearly catering to 1 million people. This is our service. These are our team members. We were established in 2013 as well, so we are toddlers compared to infants that Mark's service is. Our telehealth experience has increased, and our service delivery by mode of telehealth has increased a lot, especially in the last year, from 14 times from 2015 to 2016, and I'll show you some data about that. We are presently using telehealth mainly for follow-up appointments as compared to initial multidisciplinary appointments. But the follow-up appointments could be either multidisciplinary or individual allied health appointments as well. And often the telelink is between our pain service and the patient's home. But I will show various permutations and combinations possible with using a pediatric pain telehealth service. So data from 2016 indicated that we have more than 500 appointments that we offered for patients during the year, and about a quarter of them, 164 of them, were suitable geographically for telehealth. And the number that attended were about 84. That was the number of attended appointments. And for patients, this saved a distance traveled of more than 25,000 kilometers, more than 50 days away from home, and saving in terms of accommodation, travel, food, and other expenses of more than $50,000. And that's pretty significant, I think all of us will agree. A snapshot of a couple of patients, just to give you a feel for what kind of patients you might want to use telehealth for. So client 1 was an 11-year-old girl in Armidale. So that's a 4-hour drive one way from our service to her home. She had chronic musculoskeletal pain and psychosocial complexities. Her mother had just undergone cancer surgery for breast cancer, and she was starting chemotherapy, hadn't quite started yet when she met us. And we offered an initial face-to-face, and then all follow-up was by telehealth. After a 5-month period, we discharged her, and the client was linked back into to her local healthcare providers, including her pediatrician. And telehealth was very helpful in this scenario for this client, not only because of the distance involved, but also due to the mother's healthcare needs as well. So it's very important to really keep the patient as a center of all care. And it was very important for her to have her mother close to her. And at the same time, mother had her own health needs as well. So this is somewhere where telehealth worked well. Another client I would like to quickly show you a snapshot of was another 11-year-old girl who lived fairly close to our service, actually. She was only 26 minutes by car one way, living about 25 kilometers away. But she had had multiple spine surgeries, more than 35 at last count, for significant scoliosis from a very young age. And she had significant, I should say extremely significant, pediatric medical traumatic stress. And I know there's a session coming up later today about that. Her psychological distress around attending hospital-based clinics was really tremendous. And mother was a single mother who was studying and working. And telehealth actually worked well for this family because she didn't need to come again and again to the hospital-based clinic and could actually access this from her own home. We provided ongoing support and planning with her surgical team, which was not based in Newcastle, for pre- and post-procedure analgesia in this case, as she had ongoing multiple surgeries. So when do we consider telehealth in the pediatric pain setting? So we would think it should be considered for every clinically appropriate patient at every contact, at every opportunity, really. And one of the main things would be to consider would be that it should probably be a client that doesn't need extensive physical examination. So because that can be a bit of a barrier to offering telehealth. But however, we do, inspection is possible, and the technology is so good now that we can actually pick up on a lot of subtle signs. I have picked up tics while seeing a patient on the screen. So it is good, but I mean, we always have to keep in mind that an extensive physical examination, especially palpation and percussion and auscultation, is not going to be possible. However, again, we can have some surrogate examination by older patient themselves, like a 16-year-old might be well able to do some moves that you demonstrate and actually give you a feel for some signs. At the same time, if the telehealth link at the patient end is actually happening at a GP's rooms or another specialist or a pediatrician's rooms, then definitely we can take help of the other healthcare provider to do some of the examination that we are asking for. And in our area health district, it's used for multiple adult and pediatric services. In fact, I'm not aware of any specialty that does not offer telehealth in our area health district. Oncology, cardiology, psychiatry, occupational therapy, speech therapy, radiology, you name it. Some common scenarios where telehealth can be thought of is where the patient is located remotely. This is a common scenario where people think, maybe telehealth. Where travel could be difficult because of physical limitations, medical or financial problems, also because of carer responsibilities, especially in a pediatric context. It's very important to think what is the impact not just on the child, but actually on the carer themselves. And that might be some time that you actually have to think of telehealth. There's a significant impact for, when there's a significant impact on family, life, work, school, that's another scenario where you might want to think of telehealth. And definitely where there's pediatric medical traumatic stress, because coming to the hospital again, getting into the clinic situation, if you like, re-traumatizes these children. This list is by no means exhaustive, and you can add more and more to these, I'm sure. So some permutations and combinations of where you can set up a telelink. On one end, we have the pain medicine clinicians. That could be a pain medicine specialist, a specialist nurse, occupational therapy, a physiotherapist, a psychologist. And on the other end, it could be just the patient themselves, sometimes, in fact, often for younger children with a carer or a parent. You could also have the GP sitting in. We've had allied health clinicians sit in, practice nurses sitting in with the patient, supporting them. You could have other medical specialists supporting the patient at the other end. And sometimes you can even have a part of your own team sitting at the other end. They could be a part of another or your own pain multidisciplinary team. So with the adult team, the service I provide to Tamworth, a part of the team sits with the patient at Tamworth, and a part of the team sits with me at Newcastle. So Lots of possibilities, really. Location-wise, we usually run it out of our outpatient clinic, but can run it out of our offices as well. At the patient's end, this could happen in their own homes. And as Mark mentioned, we also hold the belief that the patient is best treated in their own home, in their own community, rather than getting them to travel to a far-off tertiary hospital-based service. The patient's end could also be in school, so there's less disruption to school in a GP clinic, in a community health center, in a specialist clinic, and even in the car, though I do not recommend doing it on the freeway. We've had that experience and that wasn't too good. What are some of the types of clinical interactions we've tried with telehealth? So definitely a multidisciplinary clinic assessment and management. Physiotherapy as well. Our physiotherapist is quite skilled in taking patients through various acrobatics, demonstrating various exercises and stretches and getting them to do it over the ether. And our psychologist is quite amazing with the relaxation hypnosis and cognitive behavioral therapy sessions that she delivers over the ether as well. She can actually put a patient to sleep over the ether. And that's kind of awesome and frightening at the same time. We also do case conferences, so we can actually link in with other healthcare professionals or schools. And schools really appreciate that because they don't have to, their teacher, their coordinator doesn't have to travel up here and find parking, or we don't have to travel up to school in our workday. And the other thing we could use it for is, of course, clinical supervision and peer support. The biggest barrier, I think, is really acceptance. Just thinking of telehealth, I think the commonest scenario, as I said, is to think of it if the patient is remotely located. There are so many other possibilities and so many other scenarios where it might be actually useful and helpful. And if we keep our care very patient-based, I'm sure we'll come up with opportunities for more telehealth in our practice. We haven't still, I think, explored a tenth of the possibilities, really. This is patient feedback data from Regional New South Wales Pain Clinic that I offer a telehealth service for. And we got a 45% response rate, which was pretty good. This is 12 months data. And what we found was 100% of patients agreed that it was very easy to communicate via telehealth, and that was quite amazing. And that is, hats off to the technology that we have today in this world. I'm sure 10 years ago, it might not have been as good. And 90% were overall satisfied with the telehealth service. And about 70% actually said they found it equal to a face-to-face appointment, and some of them actually preferred it over a face-to-face appointment. And 80% reported no discomfort due to equipment. Some of the comments were up there on the board. Saves time, money, and pain. Nervous and hesitant at first, but quickly comfortable and at ease. Felt everyone was in the room with me. Some frequently asked questions I'm addressing here, but feel free to ask later or during the breaks as well. Is high-tech equipment needed? No, not really. You need at either end, a computer, laptop, smartphone, tablet, one of those things with a webcam. And you need a good, reasonably high-speed broadband connection. And the minimum download speed has to be 400 kilobytes a sec. However, no technology is fail-safe, so you really want to have email and contact phone numbers. You want to have an open line available as a backup. This is a scenario where we would ask the patient's mobile phone or parent's mobile phone to be on during the session. Technology glitches are pretty rare. That's what we found. It's gotten better and better as time has gone. What about privacy and confidentiality? Same provisions for privacy. Legislation is the same as a traditional appointment. You do need an encrypted, secure, confidential connection. We are very fortunate in Hunter, New England, that we have Scopia as a telehealth platform that provides us with the right amount of safe encrypted connections. So patients ask us, can I just use Skype? Can you come on Skype? And the answer is always no. It's because of the safety issue. And the New South Wales Agency for Clinical Innovation website, they provide a link on their website to a safe telehealth link as well for various clinicians from Orange, Dubbo, etc., to get on and meet their patients in a virtual meeting room. However, do keep in mind that privacy of the patient at his or her location is very important. So if a patient says, I want to use a public library internet room to do this appointment, you might want to have a few concerns and talk about privacy issues there. Is it onerous or time-consuming? Well, it is a bit of a balance. Definitely before first use, a lot of coordination is needed. And there is a need for clear communication both before and after an appointment. I would presume all of us here do a lot of communication after the appointment, but telehealth definitely means you have to do a bit of it before as well. You have to allow for a bit of buffer time in case there's a technical glitch or there is more discussions or a little extended time for examination that has to be done surrogately. With repeated use, it's less time consuming and less effort intensive as well. Are there special Medicare benefit scheme billing criteria? Yes. And there have been changes in the last few years, lots of changes. There was a 2010 amendment, 2012 amendment, lots of it really. And the latest one basically says you can bill for outpatient consults where the patient is situated at least 15 kilometers away. This is to make sure that the funding goes towards those patients who are disadvantaged by their geographically remote location and, just people who can't be bothered coming to a hospital and don't access it. Patient to be located in a telehealth eligible area at the time of attendance is another criterion, and there is information and maps available on the MBS online website to look at that. However, those attending an indigenous medical service and patients of residential aged care facilities, which is not our clients, are exempt from these restrictions. I think the advantages for patients and us, it's really a no-brainer. For patients, it's less disruption to life, family, school, work, less time, effort, money spent, less resources needed, and it's actually less pain in multiple ways, less psychologically distressed by coming to hospital, by avoiding the need to come to hospital. And it's also physically traveling by any mode of transport can actually flare up pain. For clinicians, it's better because we are able to deliver timely care to those disadvantaged patients. Better continuity of care, again, because we don't have to see them so far apart because they can't travel or we can't go to an outreach clinic. We can actually offer them a fairly close follow-up if they need it. Better professional development as well as rural capacity building. I think our regional colleagues really appreciate the opportunity to interact with us during these sessions and actually get upskilled. And it is cost savings for us again because we don't need to travel to outreach clinics, and the billing is 50% more for new patients as compared to a face-to-face appointment. Again, in everything in life comes with positives and negatives. What are the limitations? Patient selection is important. It may not suit, for example, a child who's visually impaired or autistic. It might not suit where a carer is hearing impaired. So those are the scenarios where you might be better off with a face-to-face. Again, with the assessment, your assessment may not be complete, especially for an initial one. You might miss out on some subtle signs and bodily cues. And sometimes the family dynamics, the body, language can be missed out. With management, I would say if there are any medical or psychological emergencies that actually happen during the appointment, then it can be very challenging. Of course, if this happens when the patient is sitting with their GP or with a specialist like their pediatrician, then that's easier as compared to if it happens when they are in school or at home and it happens. Again, limitation of cost. With our local area health district, there is no cost at the patient end. So a patient, GP, another practitioner accessing telehealth services, they don't pay anything. However, because it will use some internet download capacity, so there is a charge involved, if you like, with your internet provider at home or in the GP service. It uses about 0.07 GB per 10 minutes, just like Skype or FaceTime. There is a cost of setup at the specialist end, but if you have enough number of consults, then that is easily offset and, in fact, very cost effective. So if you're seeing 10 patients a year or even 50 patients a year by telehealth in your service, then you have to really think, is it worth going the telehealth way? Would it be better off doing an outreach or getting them to travel down? The telehealth financial incentive programs have ended in 2014, though. A typical patient journey through telehealth, patient is identified as suitable. There is a pre-clinic link up by the admin or nurse at the telehealth pain service end. The appointment happens. And then there is a post-clinic link-up by clinicians. Going into a little more detail there, the preclinic link-up would be the admin staff checking that there is suitable technology on the patient's end, making sure they have that internet capacity, they have a webcam, and they have a smartphone or a computer they can access, checking off details, ensuring all referral information is complete. So this is one scenario where your patient can't say, oh, I'll just bring the x-rays or images on the day. So you need to have it ahead of time. Booking the appointment, sending out information, sending out a link. So in Hunter, New England, we actually send out a link to the patient's email, and they just have to click on the link, install, and they're ready to go. Installation takes 10 minutes, so it's not very onerous or long. And it's definitely preferable that they do the trial run of the link prior to the day, especially for first-time users. Post-clinic link-up, again, the admin processes billing and books a follow-up. The clinician, as I presume in any face-to-face appointment, documents the notes, care plan, follow-up. It's very important to communicate in a timely manner to the primary care provider, especially if they were not sitting at the patient's end. If you had the GP in the room with the patient or a pediatrician in the room with the patient, then that's a little bit easier. But if they're in their own home and you've had this kind of private conversation, if you like, or interaction over the ether, it's very important to convey back to the GP, because remember, if there is any emergencies or medical problems that follow this appointment, they will present to the local ED or GP, and unless you have done the communication on the day and fairly immediately, important information can be lost. And of course, information that we discuss during the appointment to be sent to the patient, that needs to be sent off as well. Could be fact sheets or resources that they may use. I'm finishing off with a list of references and resources. So the first slide, this slide has a lot of government-based and agency-based and organizational-based references. And those are articles where it's been used for various services, the telepediatric service in Queensland, in oncology services and psychiatry services, and actually a lot of papers on cost effectiveness as well of this model. And I'll leave you with this slide. So our patients travel more than 1.5 kilometers per month to attend outpatient appointments, so it makes a lot of sense for us. Your patients may not need to travel as much, but I would definitely say consider telehealth for every patient every time, if appropriate. Thank you.
Okay, so our final talk for this morning's session is going to be presented by Alecia who's a physiotherapist also from the John Hunter Children's Hospital, part of their Children's Complex Pain Service. And she'll be talking on waiting in pain, the prevalence of childhood overweight and obesity in a tertiary paediatric pain service. So, Alecia.
Hi, and thank you for the opportunity to speak today. Ideas started around this project a little while ago, and it was titled late last year. But I'll start with just... Okay, so I started working with the newly formed Children's Complex Pain Service back in 2013, the middle of the year, and I hadn't been working long before I started scratching my head and wondering, was I really in the right place? Was I at a children's complex pain service, or was I actually indeed at a weight management service? Because I felt like many of the young people we were seeing were actually overweight or obese. So it got me to thinking, and of course I asked our esteemed colleague Susie Lord, did she know what the prevalence of overweight and obesity were in paediatric pain services, to which her response was no, but that would be a good idea for something to study. So just when I was starting to think about this topic, I had a look at the literature or the prevalence and data of overweight and obesity within Australia, and firstly looked at the National Health Survey in 2014 and 15, which found that 27% of children in Australia aged 5 to 17 years were overweight or obese, and actually the overweight group was 20% and the obese group was 7%. And just for your interest, I guess, and as a comparison, 63% of adults were overweight or obese. And obese adults were more likely to die 2 to 4 years earlier than their healthy weight counterparts. So within our team, we really are working hard to close the gap, and so we're always interested around what's happening for Aboriginal and Torres Strait Islander health. So I looked at the survey, which the most recent one I could find was 2012 and 2013. And 30% of Aboriginal and Torres Strait Islander children were categorised as overweight or obese. That was 20%, again, same as the Australia-wide population, overweight and 10% obese. But you can see there that there is a difference in the way that they categorise age. So adults were classified as 15 years or older, and 66% of adults were identified as being overweight or obese. So it does sometimes make the comparison a bit tricky, but I think obviously there is probably a slightly higher prevalence, given that most of the literature suggests that the rates of obesity increase with age. So if we added in the 15, 16 and 17-year-olds from the Aboriginal children group to their figure, I suspect that figure would be higher. So moving on from prevalence data within Australia, I had a look at the literature to see what was there around obesity within paediatric pain services. And these 3 studies are all out of America. They are all retrospective chart audits, and you can see there the sample sizes. So they're relatively small, but they can start to give us, I guess, a bit of a feel for what's happening within paediatric pain services. So Hainsworth back in 2009 found that chronic pain and obesity had a greater impact on quality of life than just chronic pain alone. And I should say all of these groups were 8 to 18 years, so they're looking at slightly different age group again. Wilson in 2010 found that 38% of their young people were overweight or obese, and they found that there were increasing BMI was associated particularly with back pain and also a higher pain intensity. And a very recent hot off the press publication by Santos found that 29% of patients presenting to their clinic were in the obese weight category. They didn't look at the overweight category, they actually looked at a broader category which was called at risk of obesity, and they were looking at young people in that group with BMIs between 70 and 95. So it's hard to compare. But we get the feeling that the prevalence of obesity does appear to be higher within these services. And the American prevalence data for obesity at that point in time was around 17% obese, so excluding the overweight, so bigger again. So anyway, Santos found that older children were more likely to have a higher BMI, or higher BMI for age percentile, I should say, and obese youth had a longer pain duration before attending a pain service. Ooh. I thought there was another slide in there, but it's not there, so that's okay. So moving on to look at the objectives of my project. So I decided to try and determine the prevalence of overweight and obesity within children attending our pain service, determine whether there was indeed a trend for increased BMI or weight status to be associated with increased pain intensity, and explore if there is an association between increased BMI, weight status and other variables suggested by the literature review. So for my method, I did, like the other studies, a retrospective chart audit and looked at both inpatients and outpatients between the 2nd to 18th birthday, looking for a height and weight at first consultation. Where it was lacking, and I must say that occurred where you look at the duration in the earlier years between 2008 and 2013, where it was a less formalised service, I did accept a height and weight within 6 months of the first consultation. So there were 2 cohorts of patients in this group. So the first reflected the patients seen prior to the start of the multidisciplinary pain team, and they were essentially patients seen by Susie Lord as a solo clinician. And then, so from July in 2013 right until the end of last month, the patients that we've seen as a multidisciplinary pain team. And we did get ethics approval from the Research and Ethics Governance Manager, looking at this as a non-research activity because there was no contact required with patients' families and no identifiable information presented. So I started off with 250 patients. I removed those that were less than 2 years, which was only 1, and those that were greater than 18 years, which was 5. And of course that was really in the first cohort of patients, as our multidisciplinary pain only now accepts referrals up until the 16th birthday. there was height and weights missing for 20 patients. 8 of those were wheelchair users. So it does reflect that there's probably a little bit of a gap in our systems for monitoring the height and weight and health and wellbeing in some respects of those patients. And the final sample size was 224. So just to give you a bit of a feel for what the demographics are for our service. So the mean age was 13. There were many more females than males at 65%. We had 40% from the metro area and then the remaining 60% from regional and rural areas, which reflects well on why lots of telehealth happening. 86% of the patients were outpatients and 12% of the patients identified as Aboriginal or Torres Strait Islander. To identify weight status categories in these patients, I used the CDC, so Centre for Disease Control and Prevention calculator, whereby you pop in your height and weight data and age of your patient, and then it produces a BMI for age centile. And then from there you can identify what the weight status is. So less than the 5th centile is underweight, the 5th to the 85th centile, normal or healthy weight, overweight being the 85th to the 94th centile, and then obese being greater than, or 95th centile or greater than that. So moving on to actually see what was the prevalence of overweight and obesity within our service, you can see there that 6% were actually underweight, 58% healthy, 19% overweight and 17% obese. So looking at a total prevalence of 36% within our service, so quite a bit higher than the 27%, which was the Australian population. And if you actually add on the underweights to that group, 42% of our patients were actually an unhealthy weight. So moving on to have a look at those children who were identified as Aboriginal or Torres Strait Islander, it only was a small group, so 27 was the number. But actually looking across there, you can see that 48% were overweight or obese. And adding on the underweights, showing that 67% of that population were an unhealthy weight, so only 33% being a healthy weight. Because it's such a small sample, I did look at the 95% confidence interval, and having done that, I think we can fairly safely assume that the prevalence of overweight and obesity, again within this small group, is greater than the population. So I looked at overweight and obesity within the females, and they were sitting at 65% in the healthy group compared to males, which actually had a much higher rate of overweight and obesity, so 44% as against the 31% for females. So safe to say that probably the prevalence of overweight and obesity within our pain service anyway was higher than the rates reported for the population. Moving on to look at the relationship between pain and weight status. So not surprisingly, weight, of course, as we would expect, increased with the weight status category, as did the BMI. But interestingly, and I guess linking quite nicely into the title of this presentation, Waiting in Pain, what I found was that the duration of pain symptoms to time of referral was higher in the obese category and also in the overweight category. So those children are waiting longer to get to a paediatric pain service for whatever reason, and we can't be sure of what that might be, whether reflecting lower socioeconomic status or whether reflecting that the weight, you know, they may well have been a healthy weight and weight has increased over that duration of time. And, you know, so there's more thinking and more research to be done about why is that the case. In contrast to some of the other literature, I didn't find that there was a increased or worse pain experience among those who were overweight or obese, as did some of the other literature. I found that actually it was pretty much the same across the weight status groups. Looking at weight and pain location though, there was a pretty clear trend for there to be an increasing rate of lower limb pain with weight status. And also interestingly, the upper limb pain reduced. So you can see in the obese group, this would be a good chance to have a go with the red pointer. So this is absent. So that was the upper limb pain. And that again reflected some literature which found that, hopefully I've got a slide here, that the risk of lower limb injuries increases with BMI in children, and it reduces with upper limb. So possibly because the more overweight and obese children are moving less, they're at a lower risk of upper limb injuries, but because of their weight, higher risk of lower limb injuries. But I guess just as I am a physio, a caution for physios that when we're working with these kids, we need to keep in mind that they are at higher risk of fractures, sprains, strains, and also dislocations were there in the literature. And that was a really big cross-sectional study looking at some child population health surveys out of California. So just to summarise the findings through all of that, so 36% of the children and the adolescents that we were seeing at our service were overweight or obese, and a total of 42% were an unhealthy weight. The prevalence of overweight and obesity was higher in the male group and the Indigenous groups. And within the Indigenous group, the underweight category, there were 5 in the underweight category, all of those 5 children were actually extremely underweight, so they were less than the first centile. And some of the children in the overweight group were beyond the 99th centile, so there seems to be sort of a tendency to be at the two ends of the extremes of the spectrum. The duration of pain symptoms to time of referral was much longer in the group with a higher BMI weight status. I didn't find any difference in pain intensity across the different weight categories, but there was a higher likelihood of lower limb pain problems associated with the higher BMI weight status categories. So what are the implications of these findings for us, I guess, and you might like to have a think about your services and whether there are implications for you or whether you think your services reflect what we've found. And it just really highlights the importance of using BMI to screen for overweight and obesity. This is a draft copy of the new BMI for age charts that are being rolled out in New South Wales, and they've used a traffic light type system, which I used with my BMI weight status categories, so whereby green being the healthy range, orange being the overweight, and red being the obese range, and the IG being that, or the goal being to make it easier to engage with families in conversation around their child's weight status. I think the complications of childhood obesity are so widely documented. We do have a duty of care where we find it to address it as part of the total healthcare management of the young people that we see. And perhaps the most alarming, I think, thing about childhood obesity is obese children are much more likely to go on and be obese adults. It can be up to 78% in the older adolescents, the risk of adult obesity. And keeping in mind then that those obese adults are much more likely to die to at least 2 to 4 years younger than their healthy counterparts. So we're talking about significant impacts on actually long-term health and life expectancy. So we really do need to be addressing it. But it's a challenging thing to address. So the question really is, how do we do that within the scope of our pain service? And it's a delicate topic. I'm sure most people would agree. And I think this study quite nicely highlights that we do need to approach it with caution. So Hainsworth just last year looked at, and this is out of America as well, parent perceptions of weight and pain within a paediatric pain service. And what they found was that most parents of youth with obesity did not think that their child's weight contributed to their pain or was relevant to their pain treatment. 56% of parents did not think that discussion of weight, nutrition and physical activity might be important in the management of their child's pain. And 21% of parents of obese children indicated that, only 21% of parents of obese children indicated that weight had been discussed several times. So I think sometimes when we identify children who are obese, we can be reluctant to talk about it because we suspect often that it's been probably addressed many times by other people and they're here for pain management and you don't want to go back over that very sensitive topic, which I'm sure, brings a whole load of emotion and psychological distress for those young people. So sometimes I think we can be a little bit nervous about addressing it, but I think that does highlight that perhaps it hasn't been addressed for some of these children, or not as often as we might imagine. So there is just a little bit of data. I thought this was quite nice, this little study. So Hershey, again American, looked at 7 paediatric headache centres with a sample size of 913 and mean age of 11.9. And they found that obesity was associated with headache frequency and disability, but weight loss in the obese or at risk for overweight groups significantly correlated with decreased headache frequency at 3 and 6 month follow-ups. So I thought that that was quite nice to think that just with weight loss, headache could improve. There was quite a bit of loss to follow up across the various intervals. But it does raise the question, what is the best model of care for managing these kids who have pain and are also obese? And I guess within our service, we do a really good job of screening and we do our best to address it. We sometimes will organise a referral to a dietitian or referral to weight management programs such as Go for Fun, which is a New South Wales program. I'm not sure what exists in other states. We now have the early stages of a weight management service operating at John Hunter Children's Hospital. So do we refer these children to weight management services? Do we try and work with them between the two services? Is there a role for a dietitian to actually be a part of our paediatric pain team, given that 42% of the population were an unhealthy weight? And also given that there's some literature now around how diet can actually be a modulator in the pain experience. So lots of food for thought. I'm sorry, no good answers really there. But you can draw your own conclusions, or it will often reflect what is actually available to you in the location that you're working in. But I think it's safe to say that we all need to be aware of this problem. It's not going to go away anytime soon, although I wish I could say it was. And I think we really all need to be aware of it and upskill ourselves in our understanding and knowledge of what is good management practice for managing overweight and obesity. And thankfully for us, this is made easier by this group, Stein. Hot off the press this year, this is an endocrine group from the United States who's put together a clinical practice guideline for management of childhood overweight and obesity. So they've got quite a nice summary looking at both treatment and prevention of childhood overweight and obesity. Where to next? Of course, having done a little study like this, I now have many more questions than answers than I did in the beginning. I've answered one question, but there's many, many more now. So I guess to the future, I'd be looking to look at EPOC data. It'd be nice to look at the impact of overweight and obesity on functional disability, on quality of life, those types of things. And it would also be nice to have a look at outcome data. So what happens to these children who start with our services who are overweight and obese? Does their weight status improve with their pain management, if their pain management improves? So I'm sure there's many things that we can use data from EPOC to help answer. And I can probably extend the study that I've done just for our cohort of patients as well to try and understand more about outcomes and what happens when they finish up with our service. So again, I've got some references here. If you're keen to know more and skip the literature search, I'm more than happy to send some of these references out to you, or the links anyway. This was some of the online sources that I used. And I think now we are actually, am I the last person in this group? So I think we are actually getting to the point where we're going to be having some questions. Hopefully not all from me.
What we'll do is we'll get everybody who's spoken the same side. So I'd like, yes, please come and sit down up the front here. I'd like to thank all the speakers for keeping to time, which has allowed us ample opportunity for questions. So if anybody has a question for any of the speakers, please step up to the microphone, tell me who you are, or tell everybody who you are. Maybe not. Is it not on? Is there a...
It is on. It is. Just speak.
My question's for Hema. I'm Becca from the Children's Hospital. I was just wondering who does the screening and how do you screen for patients to determine if they're suitable for telehealth?
So the screening has to be really, it's a little bit of a discussion between the pain specialist and the CNC, the clinical nurse consultant with the service. it could be anyone really with a pediatric background as well, but I think there has to be a bit of medical and nursing input into who's suitable, just given that if they have behavioral difficulties, etc. So with our service, actually, we put a staged approach to intake as well. So we do have the clinical nurse consultant call the family ahead and do a bit of an intake phone call. So you get a little more background than what the referral may contain. We still get referrals which are two-liners, which say, see this patient for problems. So that is really not acceptable in our service. So we actually get a bit of a background, see whether the child would cope, what they've got happening to them. And if they are then found suitable, we'd go ahead with the telehealth appointment. Till date, we have not needed to abandon a telehealth appointment or abort one because it's not gone to plan or it's been an unsuitable patient. So patient selection is important, yeah.
I don't think those are working.
You can hear.
Yeah.
Di Lawrence, there we are, just got to turn them on actually. This one's working too, I think. My question is for Mark and maybe for Hema from John Hunter. I'm a paediatrician and work in southern Adelaide, and one of the people you described as previously provided services out of goodwill without proper funding. And obviously the funding of paediatric pain services is in its infancy in Australia and gaining traction. And I'm interested really, because I'm involved in the governance of services and where they sit, and I'm interested that your service, Mark, is sitting under the Department of Critical Care Medicine under anaesthetics, whereas I guess paediatricians see themselves as the physicians that look after children with chronic illness. So, you know, from my point of view, such a service is probably a better fit under somebody who provides, you know, sits under paediatric services. Obviously, the anaesthetic pain part of it is critical. So I'm interested in why your service sits there and maybe from John Hunter's point of view, where your service actually sits in your governance structure, you know, in order to advocate for these services, you know, moving into the future.
So before I got to Brisbane, the people who were advocating for the service were from the anaesthetic department, Kathleen Cook and the nurse practitioner Jules Richards, and they were kind of, Zoe was also involved in a lot of that as an OT, but had sort of been, she was one of the goodwill people who was coming across to the Department of Anaesthetics and helping us out. I think that's kind of if you look at the Faculty of Pain Medicine, most of the people with fellowships in pain medicine are anaesthetists as well, so that's just a reflection of how pain in general has grown. But I do think that there's a lot of value to having paediatricians involved and having people who are much more experienced and established in chronic health models or outpatient and rehabilitation type models of care involved in the governance. We can learn a lot from them.
With John Hunter, I may make a few comments and then leave the floor for Susie Law, the director of the services here as well. So as I understand it, with the Pediatric Pain Service, we sit under Kaleidoscope, which is a children's network for our local area health district. And initially in its inception, when it was a bit of a pop-up team and a crisis response team, like Mark said, the service provided by Susie and pop-up allied health in the wards as and when we could find them, it was kind of being provided by the pain service, which sat under the anaesthetic stream and the critical care services stream, really. But once there was a pediatric pain team that was formed, it sat more under the Kaleidoscope umbrella, which is the Children's and Young People Network. But I'll check with Susie and see whether she's got some comments there. She's been there from day one of the service, so she'd be better to answer this.
Yeah, I think I'd really advocate, if it's possible at all, once you get a full service, sorry, I'll turn this way a bit, that it moves, and it's really difficult to move the governance of a service. So my FTE originally was in anaesthesia, not that I've done anaesthetics for 12 years, but that's where, again, because of advocacy it started, but all of the allied health were actually in the children's hospital and funded by them. And when we got the monies, we were very keen, the only way to protect the medical component of the service is to actually move it into the children's hospital funding and to take it away from anaesthesia so it can never be pulled back. So you don't have to have an anaesthetist in the position. You can have any brand of clinician who can provide that service, and that way all of the staff sit within the same management structure, which is immensely good for advocating for the changes and the evolution of teams. You can't evolve a team if half of them are managed by this group and half of them are managed by that group. And so I think getting them under one umbrella is protective, and also means you can actually have better internal ability to grow and improve your model as you go, because you've got that. We sit in our structure under the paediatric outpatient services, so we're under acute services but under paediatric ambulatory care. So it's, and not that all we do is ambulatory outpatient care, but the thrust of our service is to keep children out of acute care and in the community. So that's where we sit. And I think it's a pretty good fit for what we do. The alternative was community services, but then we can't have the in-reach to the hospital quite as easily.
And I guess my last comment as a general paediatrician would be, when you develop such subspecialist services, you know, as a general paediatrician, I'll have a child who's seen by a gastroenterologist, cardiologist. They only look at that part of the child. They don't look at the whole child and all the other, you know, illnesses. So as a general paediatrician, as part of such a service, it's an opportunity to ensure that, you know, health surveillance, that you recognise other comorbidities and make sure that they're managed.
I think there's an important historical element to this, and that is that the Faculty of Pain Medicine originated through the Australian New Zealand College of Anaesthetists, and that's historically why it's been linked with anaesthesia. But I think equally the Faculty of Pain Medicine have been quite open to a number of specialties. You can enter the specialty training through, you know, either surgery or rehabilitation, general medicine or anaesthesia or surgery. So I think that's the historical reason. The way we've got around it at the Royal Children's Hospital is we call ourselves not the Department of Anaesthesia, it's the Department of Anaesthesia and Pain Management. So pain management is linked together, but it is actually a separate component. And I think it's particularly important also to recognise that it's not just chronic pain management we're talking about, it's also procedural pain management and acute pain management. And one of the advantages of being within the Department of Anaesthesia and Pain Management is that we have after-hours cover for pain. And if we were just standalone, we wouldn't be able to provide that service without significant additional resource. Rob.
Rob Lang, I'm a paediatric anaesthetist in Adelaide. This is a question for Beck and Zoe. So I'm involved in the acute pain service, but I have a specific interest in using hypnotherapy. And it was, as you were talking about the imagery involved, it's sort of virtually what we do with hypnotherapy, but I'm using it in an acute pain setting. So I was just wondering, who provides the imagery? Is that something that everyone provides? Is it the psychologist? And what sort of training do you have to do that? And then third part for that is how, I mean, that seemed like to me, but I've got obvious bias, is it seemed to be a very critical part of the whole process. Do you want the three questions again?
So I guess the long and short of it is that probably a mixture of all of us, but ideally our psychologists would do a lot of, I guess that sort of, you know, guided imagery is the most qualified person to do that. But in terms of if we're doing a functional activity, so if Beck and I are doing a physio and OT session, it might be that we use the strategies that they've learned from psychology, and we might run them through sort of the process that they've learned through that, or we may even use our music therapist as well to, I guess, add music to allow them to focus or concentrate on that imagined movement further.
And when we use imagined movements, it's very specific. So, for instance, with the case example that we used, it was Leah putting her thongs on. So it was us showing her what to do and then closing our eyes and imagining that exact specific thing. So we're not really going too far out of our scope of practice, I guess. If we need to go further and sort of delve into thoughts and behaviours or something a bit more, then we would probably rely a lot more on our psychologist.
Okay, yeah. Do you think, it seems to be that there's we're having a hypnotherapy session later today, but it seems it's something that it is quite accessible without going into, I mean, does the psychologists have a role, but just in our own hospital, I think I see that there's a need for us to ramp up our capacity to provide that service. I wonder whether we should be having a workshop to provide more access to imagery, hypnotherapy for children.
That one's tricky for me to answer because haven't been exposed to hypnotherapy enough probably to answer that one well, but definitely to open to conversation.
Yeah.
Oh, I can answer. So I've also worked with, when I was working in the burns unit, we had a hypnotherapist come to do a research project for a while, and they were using it for procedural pain in burns, and we were finding it really effective in that instance. I myself, like Beck, have not used it, that kind of thing, but I'm aware that it would be something that we'd be really, interested in knowing more about.
I was just going to say, I think it's worth appreciating that there's different goals when you're using hypnotherapy in the acute environment compared to a chronic pain clinic. In the acute setting and procedural settings, it's to try and get through a distressing period of distressing intervention usually, whereas in the persistent pain clinic, it's part of a much bigger sort of more comprehensive pain management program that's actually goal-directed and trying to improve function. So they're two very different environments, and I think that the careful appreciation and consideration of that. I don't think there's a lot of evidence in the persistent pain to show that hypnotherapy itself is particularly effective. I don't think it's particularly evidence-based. There's a kind of overlap between hypnotherapy and deep relaxation techniques, and they definitely have a role, I think, but we don't rely on them too heavily, I suppose.
Hi, I'm Janine. I'm an anaesthetic nurse from Melbourne. My question's for Alecia. With your statistics on the children, you had, let's say, 30 to 40% overweight and obese, so the other 60 to 70 weren't. Given that bodies react differently to the same diet and things, was there anything in the study to show which came first, the obesity or the pain?
No, is the short answer to that. No, it's really hard to tease that out because there's so many factors, I guess, that can play into that. But, and I'm not sure of the best way you would set something up to look at that.
Hi, Greta from Royal Children's Hospital in Melbourne. I was also interested to ask you, Alecia, have you looked at parents' BMIs in the obese and non-obese groups and bullying histories?
Yeah, no, I haven't, but the literature does look at that very widely. So parent obesity does very heavily predict the risk of adult obesity in these children. And now there's epidemiological studies looking at the weight of mothers at the time of pregnancy and delivery, and that is now showing a very high risk of those infants, regardless of anything else that happens, to then go on to become obese adults. So I think the peak time of childhood obesity was sort of around about 5 to 7 years ago. It has slightly lowered and plateaued a little bit now, but I think that was a time where there was a boom of research, and I suspect that will be ongoing for the next little while. But Hema might have more to say about that as a paediatrician.
Yes, there are, I think, multiple factors. I think it's very unusual for me to see a child that is obese and is not accompanied by a carer or a parent who's not obese. I mean, I can't think of any really, unless there's an endocrine problem or some other problem for the obesity. The other thing I was just going to quickly mention is also intrauterine factors. Studies are showing that might play a part, as in if you have a child with intrauterine growth retardation and they're born with, let us say, a normal birth weight, and they actually have a higher risk of obesity down the line because they've been, if you like, exposed to a famine kind of situation in utero. So I think there's lots of exciting studies really coming for obesity. And in this particular study that Alecia mentioned, because it was a bit of a retrospective study, it's hard to say about the chicken and egg situation and going to whether the parents were obese or not. But I imagine if we were to have a prospective study that we would do, definitely all of those factors and all of those variables would be accounted for and would have to be accounted for. It would be a big scale study, I think, which would be fairly resource intensive. But yeah, I would say there's a high correlation.
I think I can just also add to comment anecdotally from some of the kids that just come to mind that I've worked with that are obese. Definitely some of them probably started out at a healthy weight and the weight crept on with their pain and inactivity. But then there are other kids that we've worked with that were already obese, had an acute injury and then have had difficulty getting rid of that pain that's persisted for a long period of time. And I can think of many of the kids who actually the problem of obesity is a family-wide problem with both siblings and both parents as well. So certainly really challenging to address that and trying to weigh up where do we use our resources and do we work with the pain or, should we really be actually working on weight management first before we can hope to influence pain? It's all complex and many factors to consider.
Yeah, healthy.
But I think the timing of it is the main thing being really important, is because the risk is if we go for it too quickly or too early in the piece, there's that possibility that you lose the engagement with families who are there expecting pain management, not weight management.
And I think, we all tried to create a minimum data set for EPOC and, the potential there to add, child weight, height, parental weight, height, etc. is very interesting, isn't it?
Still got time for a few more questions.
Kate Sinclair from the Royal Children's Hospital. I've got a question for Zoe and Rebecca. Lateral recognition is something that develops with age, and I wondered whether with the graded motor imagery, where you think about lateral recognition and the age of the child and whether you adapt your therapy according to whether they've actually achieved that yet. You talked about developmental coordination disorder, so I wonder if you take that into account.
I think, like we suggested, it's always a clinical decision when we treat the kids and look at obviously developmentally appropriate activities for them and what they can achieve. But just having it, for us, we like to have it in the back of our minds and think, this could play a big role, and how much of a role is it playing and how much can we impact our treatment with using the principles of GMI. So one thing for us is that if we do have it in the back of our mind, then we can remember to address it. And if barriers come up, think, could that be something? And in the last 6 months, maybe they have developed a bit more. Maybe we can do something a bit different.
Yeah.
So it's not an easy linear process. It's always that stepped continuum, and just for us, more keeping that idea of GMI there, and is that a barrier?
Yeah. And are there motor screens that you use as part of that clinical process?
To be honest, we haven't really treated any kids under 7 using GMI in the last 9 months since we've been together. So if you think about a child that's 7 years developmentally, they're sort of heading towards having a lot more recognition than a younger child. So I guess we could use, if it's a developmental, an SMDA or something for a younger child, you'd have a better idea of developmentally where they are.
Yeah.
Other than that, it's really more just functional screens that I use as a physio, and I think some sensory screens that Zoe uses. Do you use any?
I think one of the things that we do as well, Kate, is in our initial assessment, we kind of treat it as a bit of a developmental assessment as well,
yes,
in that we're really kind of globally looking at where they're at in their development. And, because obviously we are seeing some kids with some delays as well. And one trend that I've noticed, having been in the sort of ad hoc service initially at Royal Children's in Brisbane, was that some of the kids I saw back then and then saw them when they were that little bit older, say sort of 5 years down the track, still having issues, then Beck's met them with me, and we have then sort of tried to then use GMI with them at that stage, because they weren't really ready developmentally and hadn't developed that sort of natural developmental recognition. So I have noticed the trend that as they've gotten older, they've been able to use it more wisely and usefully. Yeah.
Yeah. Thank you.
And probably also I should add that with our younger kids, and one in particular that we can think of, the little 7-year-old girl, her parents were a huge part of her treatment, and almost doing the recognition with them, not so much the app, but really reinforcing you need to use both sides of the body. Don't favour one side. In gymnastics, always get on, do everything both sides. So we sort of address it that way, I guess.
Hi, Ali here. I'm a psychologist and team leader with the North Queensland Persistent Pain Management Service in Townsville. These are questions probably more for Alecia and maybe Mark. I suppose I was just really curious about your idea of having a dietitian as part of a pain management service, whether it's for paediatrics or for adults, because I work in an adult service mainly. And whether or not you've actually seen in the research of any pain management services that do have dietitians, because it's come up a fair bit in our service as someone who'd be very valuable. So I wondered if you'd seen any precedents set in the literature. And likewise, I was interested that you'd actually had social work as part of your team, Mark, but now decided that that's not going to be part of the team, and kind of the rationale for that. Because again, we use social work a fair bit, but through the community for our adult service. And we've talked about having social work in our team before also. So just quite curious about those other allied health potentials.
So maybe to start with the dietitian, in our experience trying to refer patients from our service to a dietitian within our health service is extremely challenging, and the wait time can be upwards of 2 years. So, and then having looked at the literature, as far as I'm aware, no, there's not dietitians amongst adult or paediatric pain services in Australia, or I think, as far as I'm aware, certainly in America where the literature has come from. And I do think that probably, given that there is some evidence suggesting that even just weight change, reduction in weight can change pain experience, and it makes sense that actually perhaps that's, if we're thinking about treating our children and adolescents as a holistic individuals and looking at their whole healthcare package, that it's really important. And because the access is so difficult, then yes, that's where the value would come of having one in the team. And I mean, we've had a really complex young girl that we've been working with recently whose biggest problem is actually being an extremely unhealthy, underweight child. And so it's not just those children who are overweight and obese, it's also those ones that are struggling to maintain weight. And of course you wonder, how can we get these kids moving or attend to daily functional type tasks if they're so underweight, and if we're trying to actually ramp up their activity, what's that going to do to their weight as well? So, and are they, have they got the best nutrition to be able to get on top of these problems? So I think there's enormous merit in it. And of course, there's also now literature. There's a study that's just been published that came across my desk that I can't quote, but basically found that that diets high in sort of seafood and plant foods, vegetables, fruit, legumes, nuts, they've found that in that study was a direct correlation to pain experience, or improved pain experience, and also, of course, body fat, reduced body fat. So I think that's an area that perhaps there's lots of room to explore further, and hopefully down the track, dietitians do become a part of the team. And I think in the adult services, it's hard to understand why they're not, in a way, given that the adult obesity rate is so high already, and so the prevalence is equally, well, as high within adult services. So,
yeah, because we always have a nutritionist or a dietitian come through for our group, as part of our group programs. They're always a core. You've got to have them in there at some point during that program as sort of fundamental. So it's kind of curious that we haven't, as teams, considered them potentially as more of a core part of the team itself.
And of course, we're giving, the healthy eating, healthy living type messages, but I think if you're really going to address those problems that are so entrenched, and particularly are entrenched within the whole family, where any hope of changing weight really relies upon changing the whole family lifestyle, we can't possibly, I don't think, within the scope of our practice and the limitation of our resources, really do a good job of addressing that.
Yeah, thanks.
I think the idea of having a dietitian is a good idea. How it's actually integrated in the service and how you coordinate the care with yet another discipline within your service requires a lot of thought. Whether it's done in a multidisciplinary sort of model where you refer to them in a bit of a silo and have them provide input, or whether it's done in a more interdisciplinary type fashion. So I think with the question about social work, it was really challenging having 5 disciplines all at similar FTEs in our team, and trying to coordinate an assessment, an interdisciplinary assessment with that many people on the team. It impacted on all of our ability to do the assessments that we each individually needed to do. Blew out our formulation session, it made us run late. It was really challenging to have that many people involved. And similarly, it was challenging to have 4 to 5 health practitioners wanting to treat the one patient and family in the follow-up after that as well. And there were occasions where patients would have to come in on multiple times, on more than one day during the week, just in order to see all the practitioners, or that they'd have to spend 3, 4, 5 hours in the hospital just to see all the practitioners. So I didn't think that was particularly patient-centred, and I didn't think we were getting a huge amount of benefit out of having that extra resources for in terms of outcomes. I think systems can get too complex, and there's a lot to say for having 2 or 3 health practitioners seeing patients instead of 4 to 5 or 3 to 4 on a regular basis, in terms of ability to be on the same page and coordinate care in that interdisciplinary way much better. I think the other thing, social workers as a population have very different skill sets amongst them. The social workers that we had came from a PICU background. They did excellent psychosocial assessments. Their agenda was very much an advocacy support type agenda, and that did clash with the therapeutic agendas of the other practitioners and my own sort of agenda as well. Obviously, child and youth mental health services, a lot of social workers work in those services, and they do a fantastic job. They can be, I've seen them be extremely good family therapists, and also provide other psychotherapies with the right training. So I think if you're looking at having a social worker, and there is a role for advocacy and support as well at times, but if you're wanting a social worker in your team, I think you have to be clear about what you want that role to be and how it's integrated.
Yeah, good. Thank you.
Okay, we've run out of time for questions. It's now time for morning tea. How long have we got, Jordan?